wait a minute. Oh, you hurt arm, not leg.
Oh, I forget it. Oh, oh,
No, no, no. Oh,
oh, oh.
how can I help you?
I hurt my arm so much because I play football with my friend.
Oh, where do you pain is?
I think it's around my forearm.
It may be radius or ulnar fracture. Wait, but you play football? Oh, why you hurt your arm?
I play football with Manny Pacquiao.
Hey, you deserve it. Okay, you go through there. The X-ray room is the right side. Okay.
Okay.
I will just go to consult with my team. Okay.
Thank you.
Okay. Okay, hello everyone.
Hello.
Hi. Okay. Today we have a patient with radius and ulnar fracture. And this is X-ray film of our patients. Wow, that's bad. Who can explain of radiography of this?
Yes, I can.
Okay,
Let me see.
here you are.
Thank you. I think the radiographic finding in case of suspect mid-shaft forearm fracture, anteroposterior and lateral radiographic showing the entire length of the radius and ulna are unusually diagnostic because the radius and ulna overlap on the lateral view. Additional oblique views may improve assessment of the fracture. Dedicated view of the wrist and elbow are usually obtained to rule out concomitant injury to this joint. Radiograph should be evaluated of adequacy and the fracture themselves for displacement, shortening, angulation, use of radial bow, orientation of the fracture apex, and comminution. Several important injuries are easily missed when assessing forearm radiograph, and special attention should be paid to the following area. The integrity of the distal radio-ulnar joint should be carefully examined, especially in case of radio shaft fracture to determine whether aggressive fracture dislocation exists. Signs of a disturbed distal radio-ulnar joint include ulnar styloid fracture within of the distal radio-ulnar joint on the posterior anterior view, dorsal displacement of the ulna on the lateral view, and radial shorten of 5 mm compared with the unaffected limb. Signs of distal radio-ulnar joint injury may not appear until day 2 weeks after the fracture, as the forearm musculature exerts deforming force even after the forearm has been placed in the chest.
Okay, thank you. Okay, thank you. What about anatomy of this?
Yes, I can.
Okay.
Let me do this. The anatomy of the forearm is complex, and only important considerations relevant to difficile forearm fractures are presented here. The ulna and radius are joined by 3 major groups of ligamentous fractures. The triangular fibrocartilage complex, including the distal radio-ulnar joint, the interosseous membrane, and the ulnar ligament with adjacent proximal radio-ulnar joint. These structures maintain bony alignment and stability while allowing pronosupination. The radius is notable for its round head,
which articulate with humeral capitulum and rotate within annular ligament during pronosupination. The radial shaft has bow architecture that allow it to rotate around the ulnar shaft. Lot of this bow shape results in decreased range of motion with pronation and supination. The distal radius broadens to large metaphysis, creating a stable articulating surface for the scaphoid and lunate. The radius has nutrient artery for foramen on its volar surface, approximately 9 cm, distal to the radial head that can sometimes is mistaken for a fracture. Yes.
Okay. About mechanism of this injury. The bimodal distribution of mid-shaft forearm fracture reflects the two primary mechanisms of injury: high energy trauma, e.g., motor vehicle collision, sport injury, from high account for the large number of forearm fracture among young male with good bone strength. Low energy trauma, primarily fall from standing, account for the large number of fracture among postmenopausal female, attributable to their decreased bone mineral density. Specific fracture pattern often result from particular mechanism. Both bone forearm fracture require high energy, most often involving a motor vehicle collision. The injury may be sustained from a direct blow or an indirect injury involving a bending or rotation was placed on the forearm. Knife stick fracture almost always result from a direct blow to the forearm, often while the victim was using the forearm to protect their head or torso from a blow. Gallicii fracture dislocation usually result from a fall onto an extended wrist with a hyperpronation forearm, a fall onto an upper extremity with an extended elbow, and a hyperpronation forearm is the most common cause of Monteggi fracture dislocation. And what about you?
Yeah. Let me see.
Okay.
I will tell you about the complication of this. Fractures are susceptible to a range of complications, which are reviewed separately. The potential for complication with mid-shaft forearm fracture sustained from high-energy trauma is relatively high. With all mid-shaft forearm fracture, poor anatomic alignment, especially loss of radial bow, with secondary lost range of motion, is a significant concern. Minimize the risk of major reason for surgical treatment. Additional important potential complications include the following: 1. Nerve injury, including acute laceration or entrapment and chronic entrapment during fracture healing. Radial and median nerve most commonly affect. 2. Wound infection is approximately 0 to 3%. 3. Acute compartment syndrome, approximately 2% after open reduction internal fixation. 4. Myositis ossificans, heterotrophic ossification. 5. Malunion and non-union, approximately 2 to 10%. 6. Radial ulnar synostosis, approximately 1 to 6%. 7. Symptomatic surgical hardware requiring removal. Next, of note, nerve entrapment involving the radial or median nerve may develop days to weeks after the initial injury. Suspect post-fracture nerve entrapment should be investigated with magnetic resonance imaging, or we say MRI, or by an experienced musculoskeletal sonographer. Entrapment often require surgical exploration and release. The sign and symptom of radial and medial nerve injury are described. Thank you. Hey, wait a minute. This is Dr. Pongpas. He come.
Oh.
He come.
Sorry, I'm late.
No.
Okay. Can I ask you something?
Yes.
Okay, we have a patient
Uh-huh.
with this. You think he can return to work or sport?
Can I do the film X-ray?
Okay, yes.
Thank you. I think rehabilitation typically begins once a case is no longer needed or immediately following surgical fixation. The major goal of rehabilitation are to help the patient regain pain-free function. The range of motion and full strength in the injured extremity by neuromotor control is generally regained with little difficulty. Decisions concerning return to work or sport are based in a part on the severity of injury and the presence of any complication. As rehabilitation can begin immediately following surgical fixation. Athletes and heavy labor often choose surgical fixation since it will speed their return to play and work. The sport and the work demand of the patient must be considered in both the design of the rehabilitation program and the criteria for returning to activity. Return to work or sport requiring heavy or repetitive upper extremity loading typically require 12 to 16 weeks of healing and rehabilitation. Return to work that place field demand on the upper extremity typically require 8 to 12 weeks. As with any fracture, the time need to recovery and vary widely depending on the injury, activity, demand, and individual rate of healing. So, as rehabilitation progresses, it is reasonable to resume gradually from activity level, beginning with light duty and work or non-contact sport practice, before being permitted to begin full participation at work or sport. The patient must demonstrate sufficient strength and dexterity to complete or require physical tasks. We suggest that an athlete return to sport be supervised by an athlete training whenever possible.
Okay, thank you for your information. I will go to talk with my patient.
Good luck.
Okay, bye.
Pongpas, where we go?
Oh, I am going to the patient.
Oh.